true objective data.
This meeting is being recorded.
Yeah, sorry, I hear that. It's recording now. So this is much objective data um, from cost reports, right? So that's where we're starting with this. So this is what folks filed on their cost reports that receive Medicare funding. And you can see that some occupancies decrease. But what I thought was interesting about this was that the margin itself, this is what's reported for margins of cost reports. But if you exclude all of the federal grants, the count talk PHE funding, but all the provider relief funds and any other federal grants that were received, actually margins were negative in 20 for nursing facilities. This includes all nursing facilities, for-profit, nonprofit. And then it was even worse in 21. So the median or the midpoint of all nursing facilities were losing money. Some of these nursing hours per day, these include non-productive time. I have stuff in here that includes direct care. So I'm going to focus on that when we talk about mandates. Then CLA itself, using all of the 12,800 nurse facilities in the database, then said, well, okay, well, how's 22 going to end? If we take the full year of 22, and said, let's assume occupancy is 81%, recovers from what was in 21, gets up to 81%. Well, it's still negative 3%. And this is including, everyone keeps their provider relief funds and CARES Act monies. And there is no clawbacks. It's the same reimbursement, no decrease in reimbursement. And margins are negative. So even when CLA was looking forward to 22, 22 is not going to be any better than 21 from a margin standpoint. And for those that have occupancy, about for the whole year as an average where it was for 21, it's negative 5%, negative 3%. So when you're talking revenues of $10 million, $15, $20 million in nurse facility, these numbers add up. Right? These are the margins on that. Speaking of labor, and I know folks in the industry are well aware of labor challenges, but just from a data point, the industry lost 338,000 from lost jobs, and that is taking data. I'm looking at it, just taking data from March 20 through March 2022. So if you just compare the positions and jobs in skilled nursing properties facilities, that decrease is 238,000 from the nursing workforce, right? So, and then here we're going to talk about mandates later, so it's kind of laughable at that point. But you can see there's already a drop in staffing. And then, as we know, there's already a 5-star staffing rating change. I'll speak to some of those changes later in the presentation. The wages itself, everyone's aware of inflation and hiring and incentives to hire. But just for a data point within what's filed within cost reports and objective data point, you can see that it was up 8.1% for overall nursing positions. But when you drill down to within those positions, the aide had the highest increase in 9.7%. So I think it's new news to y'all. This is an objective data point for actual increases within cost reports of hourly wages. Contracted and agency nursing cost trend. I'm sure providers were well this too, but you can see that this is data pulled as well from the cost reports and post-COVID, that you can see that nursing cost per hour increase of for the providers itself. So you can see nursing contracted nursing costs per hour have increased 2 to 3 times historical levels from where it was pre-COVID. And when we pull from the cost reports itself, those that had hours paid to nursing pool, you can see that's increased well. So 66% of facilities are using nursing pool within 21 data, right? When in 17, it was 36%. So almost double actual number of facilities. And utilization itself, I thought, you have the data in here of that nursing pool hours as percent of total nursing hours. This is just taking of a facility, how much of its hours percentage-wise were nursing pool, right? So you're like, 5% to 3%, these percentages look kind of small. However, if you take 3% to 5%, that's close to 100% increase. It's like 80% increase from 3 to 5.5, right? So it increased significantly on nursing pool hours. And then this 75th percentile, which means of all the providers, that was like at the midpoint of the 25th worst, all right, of highest nursing pool hours. There's a quarter of providers out there that are 14% or higher in their nursing pool utilization of their total hours. And from a provider standpoint, you don't want to do that, no matter what any accountant says or financial person says. I mean, you don't do it for your residents, right? You wouldn't want consistent care providers for your residents. So it's creating challenges for facilities all over, much less from a cost perspective or margin perspective. Contract share by quarter. This is the quarterly data, but I think I've kind of proved my point on nursing pool and contract time. This is more margin data, but this is broken down by star ratings. This is a correlation of saying, okay, well, for those that were 5-star, the data before was just a median standpoint, right? So if you splice it, said, okay, well, my facility is a 5-star, and that could include a bunch of for-profits that are 2, 3-star or something like that, right? So just from perspective basis, no, even the 5-star, once you back out the provider relief fund monies, they're losing money too. As I spoke to earlier, all those grants are, drying up, and now employer retention credits are gone, soon to be gone, and people are doing what they can to get whatever else they can. But so it pretty much says the grants are drying up, and so expect negative margins going forward without significant change. This is a data point on occupancy. So there's a positive correlation with occupancy and 5-star. This is based on the historical calculation of 5-star, by the way, but there's a correlation. Now, what's interesting though, it's not necessarily completely positive correlation of 1, because the 4-stars have less than 3-stars. So, but there is overall a trend line of higher occupancy with higher rating. So, okay, so that was pulling from cost report data and national data in it. If we just focus on Maryland itself, how are Maryland occupancies going? So this is from weekly occupancy filings and most recent data available. And this had, in Maryland, it's stabilizing. It's higher than national, which is positive, but it is stabilizing. It's in this 80 to 83% range, 82, 83. You can see it stabilized around there post-COVID, which is below pre-COVID levels, but it's higher than national. But you can definitely see a trend line of stabilization around the low 80% in nursing occupancy within Maryland. This is a snapshot I thought I'd share, and as Allison mentioned, the presentation will be shared, but this just has by county. They just pulled the last filing weekly occupancy, what it was by county. So it's just maybe of interest that you can see the higher counties, and it does appear to be some in the Montgomery, PG, Prince George, PG County, Montgomery, they're close to DC. They're at the higher end. You got Frederick, it's kind of DC metro, suburban, that's on the higher end. Baltimore City's higher too, but then they're going to decrease in Southern Maryland and the Eastern Shore. This is another just data point for, as we look at some of the, when I do some quantifications, I speak to the cost per day if a mandate's implemented in dollars and whole dollars. So I'm pointing out to say that if we're greater than 50% Medicaid in the state, and there are discussions or when Medicaid gets adjusted, and announcements for adjustments are coming up, you can see what it'll cover potential costs from staffing mandates, right? So staffing per resident day, this data includes, this is from filings within the quarterly data. And I want to point out, so in Maryland, you're stabilizing around 3.8. This is including LPNs, RNs, and aides in it. And this does have all of the DONs and some of the RN administrative positions in it, whatever was shared. So I'm pointing that out when I speak to some of the quantifications later, but it is stabilizing, I guess, is the overall gist of this slide. The overall takeaway is here we're back to where we were about Q1 2020, right? Which is when COVID first hit the nation. It was known publicly in March of 20. So we're back to those levels from a staffing point. Okay, so now we have these breakouts of slides, and I'm breaking this out because this is a data point to look at and some context when we look at the mandates later. And these similar breakouts for we took all the 220 facilities in Maryland, which was from the Q1 of 20 provider-based journal submissions. So you have to file as part of your 5-star rating. You have to file quarterly staffing of direct care staffing for your 5-star rating. And pulling all that data, 220 facilities that are in Maryland, we have the average bed count was 138 beds. The median, the midpoint, so around number 110 in the ranking was about 130. And then the 90th percentile is about 200. So somewhat bigger, but there's some states like New York that have 300, 400 bed facilities. So not as big not nearly the number of facilities, but also the beds within a facility, not as big as some states. The average is about 138. And look at occupancies, it's 78.8% is the median midpoint from that quarterly filing. This was near Q1 of 22. The average is 72, which means that there's some that are down low, they're pulling this. And this, from the occupancy percentage calculations, you just note this is from licensed beds, this publicly available knowledge. I'm well aware that some providers have shut down wings that aren't currently available to residents, for workforce reasons. But this occupancy percentage is based on licensed beds, public data. And then we get to the direct care hours per resident day. So this is where we start looking at, okay, within the provider-based journal filings, PBJ filings, what were the total number of RNs, LPNs, and aides per resident day? And so you see the top, at 3.46. So some of the mandates out there, are 3.5, 4.1. So you don't really need an accountant to say that, okay, well, we're below the mandates if they come out, because the midpoint facility in Maryland was 3.46. The average is 3.64, but that's pulled up by some facilities that are just really highly staffed for their number of residents. Then when you drill down, there's breakouts here for aides, and there's breakout for licensure. That's because some states, they have a minimum for license positions, which combines RN and LPN. And then you have a breakout for LPN and RN. And no state breaks out LPN. New York breaks out license mandate, and DC breaks out RN mandate. So, there might be some states somewhere out west, but the states in this presentation, which pulled New York, Pennsylvania, Maryland, DC, does not. Okay, so we have those breakouts here. So, and this is good information, I guess, if you're in facility, if you're in budget season, right, come up for next year's budget, and you're probably in the final points of that and those drafts. This is some data straight from the staffing, provider-based journal staffing of positions. Breakouts in here for sizes of communities. I'm not going to go through all these in detail, but I think this is good information for you as you're going through. I mean, clearly those facilities that have less than 100 beds in Maryland, which are 56, they're not as efficient from a staffing standpoint, just because of size facility. You get to 100, 129, it's a little bit more efficient. What's interesting though is that when you get to the breakouts for those like greater 160 beds or 57 facilities, they're less efficient than the 130 to 159. So when you take up those facilities that were within that size, the number of beds, that's the most efficient quadrant. So there's something there to efficiency and size facility. When you get too large, they're not as efficient, but that in that 130 to 160 and 159 range are the most efficient facilities from a staffing standpoint. So I got these breakouts too, when we quantify the impact of mandates. So then the market, I put some market in here. I'm not going to go through this with detail. This is good context for you. Just, our accounting firm CLA pulls market data quarterly from NIC data. So I have breakouts in here. We have a breakout for the Baltimore and Metro Baltimore. I have a breakout for Metro DC. And I'll speak to those in Maryland, part of Metro DC. So population trends, Baltimore overall similar to trends nationally, nothing new there. Baltimore does have positive trends in workforce and caregivers potentially. I mean, the numbers are there for the age and unemployment. So it appears like there's more opportunity in Metro Baltimore for hiring in workforce than someone, for example, in like PG County or Montgomery. I'll show that slide later, but you'll see they have lower workforce ratio and have lower unemployment. So it's tougher for hiring. There's a consumer price index. You can see updates in here for the area. So Baltimore, it's increased over 10% from consumer price. This is some interesting data from occupancy standpoint. Baltimore independent living is stronger than national trends, and its nursing is stronger too. Assisted living is not, and the same goes for DC. There's something too within this Mid-Atlantic region and DC, Baltimore, Philadelphia area, even parts of northern New Jersey, where there's a lot of assisted living. And I think it's just for-profits have come in, built a lot of assisted living, and will market their product as memory support or standard assisted living and bring in residents at a low room and board rate, and they'll have additional charges and acuity charges, things like that. And there's just been a lot of that in this Mid-Atlantic region. So assisted living is more challenging from an occupancy standpoint compared to nationally. And then some other things, construction. So overall construction in Baltimore is similar to national from a senior living standpoint, nothing very similar nursing mix. Now it's not the same when you look at Metro DC. And for this context, this includes Frederick County as well, for the Montgomery, Frederick, PG, and parts of Southern Maryland. So stronger population trends, but it's interesting that the growth in DC is stronger than national on the less than 85-year age. It's very strong. So you can see what I'm speaking to within DC itself. It's strong growth there. So it could be opportunities for, I would think, there's private pay, more active adults. So there's opportunities there within the Metro DC area. We have a cost increase for DC, but I did want to note that in DC itself, which I know I'm talking to Maryland folks, but just for context, when you see DC data, DC itself did during COVID, during the emergency, and it's still in effect until the White House declares the end of the emergency. They're getting a 20% premium on their Medicaid right now in DC. Okay, so that's assisting nursing. DC independent living stronger, and then AL is the same thing as well, but AL and nursing are lower in DC. So a lot of that, I think, in DC and Metro DC, Montgomery, PG County, is workforce issues. It's just tougher you can see it right here. Lower unemployment, the workforce ratio isn't as great, and then the wages for aides are challenging, right? So it's tough. I think even though it's tough workforce issues in Metro Baltimore, it's tougher in Metro DC area. Okay, so now just from all that market data, a lot of it's contextual data. I think it's from workforce and margins. So you have that objective data point when talking to boards and other management team members about it. When we take a step back and talk about the nursing mandates that are out there, I selected those in the Mid-Atlantic and some comments on what CMS may do at a national level and what's driving it. But currently within the state of Maryland, it's minimum 3 hours per day and has a direct care positions as well. And then there's a comment there about DON as well, if they're providing care to nurses. In Pennsylvania, last year, you may have heard a lot of news just due to its proximity of Pennsylvania doing a 4-1 direct care hours per resident day was what the governor had mentioned at that point. And there were some proponents of it as well. And also CMS has mentioned 4-1, which I'll speak about CMS, but it's definitely turned to 4-1, and 4-1 would have been significant. I mean, the current Pennsylvania mandate was 2.7 to 4-1. I mean, that's a huge gap, a big delta, right? They'd have to staff up to. It did get decreased to 2.7, but the final regs are not out. The Governor Wolf had mentioned before they leave office in 2023, they want to finalize the regulation. So the calculations in here about this 287, but there were comments about minimum shift ratios, which for nurse assistants, and I haven't seen that. The data's not out there, but I mean, that could play into it too, right? More so than the 287. In addition, the state of Pennsylvania has mentioned a 70% expense for direct care, but they haven't defined that calculation for the accountants. Is that revenue, what revenues are included, and then for the expense side as well, as a percent of expenses. Then you delve down to related parties and outsourcing and things like that, where accountants and attorneys could manipulate some algorithms. Let's put it that way. So I haven't seen that calculation. So it's right now the final number within Pennsylvania. They've agreed to a 287, and that agreement was with the associations there in Pennsylvania. In New York, so New York is it's in effect. So in New York, besides DC, New York's been the first out. New York took a hard line, and that became in effect April 1. They extended till April 1. It was effective. The hours basis is what's in the provider-based journal submission. So that's nice because, like I said, it's the Maryland, its rule was pre-provider-based journal submissions. So it has DON assistance, which may or may not reconcile to what's submitted on your quarterly provider-based journal submission. But here New York said, okay, just base it on the same thing CMS is using, which I guess is nice for reconciling to make sure consistent. But they are 3.5 hours of care per resident day. So we don't have to here was the data. When I went back and showed the data, for within Maryland, we're at 346. So we already know there's going to be a gap there if what's in New York were implemented in Maryland. Then they have a requirement of 2.2 of license. So that means non-aid. So it was LPN or RN. I'm sorry, 2.2 of aid, and then 1.1 that's got to be from a licensed nurse. So that's LPN or RN within the rate. So they have a few minimums within the 3.5 itself you have to meet. So you can't just staff 3.5 with all aides except for one RN on duty during the shift. DC's nursing staff mandates. It is one of the highest in the country at 4.1, and then 0.6 hours present day is per an RN. Now that is very high. However, I do know, during COVID, emergency of COVID, they were allowing some facilities not to meet that, right? So it's something that's really high on regulatory standpoint. But what was actually being implemented and enforced during COVID was not the same. Then DC does require, though, which has been terrible for margins, require that if you don't have the staff and you can't hire the staff, no matter how great your HR team is and your culture, if you can't hire the staff, they do require attempts being made of temporary staffing, right? So then there are some temp agencies, which I'm sure they care about residents. I'm not questioning their care for residents and how they provide care, but if there are a few temp agencies within DC, they have the ability to, they have more leverage for setting prices, right? So that's tough on margins as well. And if that makes it in the mandate from CMS, that's going to be tough for some marketplaces. Then we have CMS. So CMS right now, there's nothing definitive from them. I guess they're still in information collection period. They said their contractor Apt Associates is collecting information about not just the care for residents, but also feedback on cost. That's what they said. So we'll take them to that. I know their associations, Leading Age, the national for-profit ones, they are rather vocal on this matter and provided input on the staffing mandate and the costs and what it would do to resident care and things like that, and number of residents. So they're still in collecting information stage. The White House set a goal of March 2023 for it to be in place. Now, CMS and its data, if you just Google CMS 4.1, you can see that they've mentioned this as a direct care per resident day. And there was an academic from some university in California that mentioned this 4.1, and that was their basis for it. And based on their estimates, that there's a positive correlation between the staffing and the quality of care. And let's look at the 4.1 at that point in time. But CMS, even when they mentioned 4.1, they recently revised and updated their 2023 proposed payroll. So they recently announced the reimbursement for effective 10/1, October 1 for their fiscal year ending 9/30/23, and they mentioned 4.1 in that as well. So it appears like that could be it, right, for the direct care per resident day. So then, okay, so we got the information out there on mandates in the Mid-Atlantic and some of the states that may influence the CMS, or well, I know they influence CMS, and DC does as well. So then how do the calculation? So these are the assumptions in it. We could talk about assumptions. I welcome feedback on assumptions. I say I want information to be as useful to as many people as possible. But the point was taking known data, right? So taking filings from most recent Tri-Base Journal data, Q1 of 22, right? So I didn't try to select some communities for summer of 22 or August of 22. I just said, what's the most recent objective data out there? So it was PBJ filings Q1. And then cost reports. So we use all the cost reports filed from 21 and 20 for the wages and the benefits placeholder. And I'm well aware there's been cost inflation. Since then, in 22, lots of raises. I'm well aware of providers I work with that have had to raise, for what they charge residents and also for their employees during 22, right? But this was just what's an objective data point there, so no one could argue with saying the data is wrong or too high or something like that, right? So it's objective data out there. So it took the cost reports. Then forgetting to do any mandate, started with aides because of the lowest pay rate. Then use as many aides as possible, then went to LPNs next, then RNs, right? So purposely try to be conservative on the quantification of cost. And then raises, I think it's understated. Well, we know wages and benefits have gone up since 2021. This does not factor that in. Did not assume additional nursing agency, just took wage and benefits costs from cost reports. If you had to fill the gap of nursing agency, clearly the cost be higher. And another thing we didn't factor in was what about increases in occupancy since, because this is the PBJ filings of Q1, since Q1, right? If there's more residents, you'll need more staff, right? But did not, just took occupancy at that point in time, did not make an assumption of higher occupancy. Conversely, which I think is a potential likelihood if mandates and when mandates are enforced, there could be drops in occupancy, especially some of the providers that just are not making margin, and they will be, I think, be more selective on who they admit to their community. They'll select those that can pay, right, and staff down to that, and staff to the residents that can afford to pay for it. So I think that's a risk, right? So we didn't do that, but there's a, I did point in here in the presentation on slides that for every 1% decrease, and assuming the average resident stays 90 days within nursing, which is a mix of Medicare and Medicaid, then it's like 1,200 residents or 1,200 seniors that wouldn't be serviced for all those drops. Okay, there's also a breakout in here. That's just context. I have a breakout in the cost by region. I broke out the separate regions because there are differences in costs clearly based on regions within Maryland itself. I mean, Western Maryland and Eastern Shore are much different than Metro DC or the capital region per this graph pulled off the state of Maryland. Okay, so this is where I pulled. Now, the Maryland regulation, when it was written, was before PBJ filings. Okay, so just for whatever it's worth, though, I just pulled what was the RN, LPN, and aid staffing within PBJ that was submitted, and there's some communities below that. So, you know, and also there could be within the state of Maryland, you're allowed to use DON for direct care. So when folks, you know, submit to their surveyors or regulators in Maryland, Department of Aging, things like that, they might be able to get at, you know, increase the staffing. But if you just take what was filed with PBJ to the mandate, there was some decrease in extra cost. And so this was for all the communities 220. There's a breakout for costs by size of facility. And we've got the region breakouts as well. But if you take for those facilities that were below, and if the Maryland mandate's translated to saying, okay, the current Maryland regulation is translated to say, well, you have to follow PBJ or reconcile to PBJ. For those that are below, it costs each facility $176,000 or an extra, you know, $5, $4.99 per resident day. I mean, look at staffing. If the Maryland regulation is reconciled as a tie to PBJ filings, you know, then you have to hire for all the facilities. We're missing 145 nurses for those facilities that were below it as well. Pennsylvania. Now, Pennsylvania is not as right now it's 287, and we know the details on the shift requirements for nursing aides and nurse providers, things of that nature. But that was a little bit less. I mean, it's still a cost, but for those facilities, if they have to meet the Pennsylvania mandate, it'd be $191,000 per facility on average. They have breakouts for those communities. I mean, some of the larger facilities, you know, the costs are lower because they're a large facility and can spread the cost per resident day. So you got the hiring as well, the staffing as well for Maryland, but it's not as big. I want to focus more on New York and DC. So if you take New York's, which is 3.5, we already went over the graph that showed we're below that, the midpoint. So that means over half of the facilities in Maryland are below New York's current mandate in Q1 of 22. If that were required, we just were to take New York's mandate and layer it and apply it to the Maryland facilities, it costs a total of $46 million of extra cost, assuming occupancy stay the same. I mean, one way would be you decrease occupancy, all right, and you keep your employees. Maybe another way to solve the equation. But if you keep occupancy the same, be extra $46 million. And for those facilities that have to implement it, that are below the threshold, they're going to have to spend $397,000, about $400,000 per facility. So it's a serious dollars. And then, you know, so we're in a range for the smaller communities, smaller facilities, you know, 329 up to about 468, 470 for the larger ones, what they'd have to spend. Then we have breakouts by region itself too, but an extra 400,000 expense per facilities for those that are below it is significant. Then we have estimated staffing. So the staffing need, if you were to take the New York regulation and layer it and apply it to Maryland, you need another 1,000 nurses from somewhere to work in Maryland facilities. And you need, you know, 2.2 million staffing hours from nurses from somewhere to work in our facilities. Then we have the DC mandates. The DC's mandate, how it's written in regulation, is the highest currently. One of the highest in the country. It's definitely the highest in our Mid-Atlantic region. But if it were enforced, its current level, we're talking 133 million total extra cost to Maryland facilities. On average, for those below, 728,000. This is my placeholder of an extra $19 per resident day. So this is where this is included to say, okay, well, if and when the regulators are going to say you have to meet this, if it's a 4-1, then we need reimbursement on average to go up for our Medicare and Medicaid to go up $19 to pay for this staffing, right? Is what that's really saying. It's taking that cost per resident day. And then for those that are large facilities, close to $1 million, 957 of extra cost or below. For those that were less than 100 beds, 500,000, but still 500,000 is a lot of money and extra cost per resident day. That has to be met somehow. We have extra staffing. If the DC mandate is applied to Maryland facilities, we're at full-time equivalents, 2,400, so close to 2,500 extra staff nurses have to be found from somewhere. And these are full-time equivalents. These are not including part-time. So, full-time and part-time, you have a higher number if the mix is part-time, which it is in nursing. There are a number of part-time nurses. So, but full-time equivalent standpoint, over close to 2,500. And from staffing hours, you need over 6 million extra staffing hours if the Maryland mandate is applied to all Maryland facilities. So it's significant numbers. At a certain point, it becomes, you can talk about a high number because some of these numbers are so challenging. Even if the nurses were out there, the numbers are challenging to achieve. So just from taking a step back of saying, if CMS does a mandate similar to New York or DC, the average cost per facility for those who have to meet it is $397 to $728. And the staffing needed from 1,000 to 2,500 of nurses, of full FTEs, right, needed. So those that work 2,080 hours a year. So significant numbers if those mandates come through for cost. I put in the sources just how the calculation occurred, but for some of those in the cost reports that didn't have, for whatever reason, they filed the cost report. Who knows why? I don't really care why, but for some reason that they didn't have the cost in there. I put the assumptions in here, which were close to the averages you see in the data, but I just pointed that out. So from a regulatory standpoint, we got the 5-star staffing rate changes. Like I said, I know Leading Age has been a thought leader in this and already provided a lot of data on 5-star. So I'm not trying to duplicate that as well. But the gist is that turnovers more is included more now. The turnover positions that left for the 12-month period. They have case mix adjusted RN staffing levels as well. And then you already knew this from including facility employees and agency staff. But there is an inclusion of DON and RNs with administrative duties. Now, the verbiage in there is about DONs and RNs administrative duties that with direct care to residents. So I don't know how to define that, right? How much is a DON or an RN that's administrative duty involved in direct care and to what degree and all those things. So anyways, I guess my point is that it looks like if there's areas within this calculation that appear more gray to me from an accountant standpoint, it's this whole the DON and RN's administrative duties and how much they can be included, fully include them based on position or what percentage, things like that. So that's a little bit of gray area as well that could be incorporated in a mandate calculation. Staff rating measure scores. I know that looking at my notes at Leading Age Maryland, I provided data that for those facilities that if you take all of the communities, for-profit, nonprofit, governmental, based on new calculation, 28% would lose a star in overall rating, but then 5% would gain a star, right? So I'm not going to go through all the star rating calculations, but based on it would be a drop in stars itself. From SNF payment rates, it was, I don't even like to say we're positive, but it was positive in that, expecting what they call neutrality, which is government speak for when they first incorporated PDPM, they thought it'd be neutral reimbursement, but actually it went up 5% after folks were using the new codes and acuity codes. So then they said, we're going to lower it 5% to get back to neutral level. However, they have agreed to increase 2.7%. And then They're saying they're called a recalibration adjustment over 2 years, 4.6%. So they're still lower at close to 5%, they say, but they do over 2 years. But then they also increased 2.7%. So it's not as bad. And reimbursement overall did go up, right? So there was a positive increase in Medicare reimbursement. Yes, this is I already spoke to that they unintentionally reimbursement at 5% when they did PDPM. And then overall included for 2023, 4.6 adjustments. So positive reimbursement. There are new measures for QRP. There's a new measure in fiscal year 24. So for 9/30, year ending 9/30/24, for flu vaccine coverage among personnel. As part of that QRP, the quality measure they're going to use, and then the COVID-19 vaccination coverage amount of personnel. So it's just a heads up on that coming out in the future as well. And they're expected to continue to reduce the per diem by 2% for those facilities over the next 2 years. And speak to some future updates as well that they're planning itself. I'm flying through some of this. I realize it's 12:45. I want to save some time for questions or mandates itself. So it's future. So let me pause there and see if there are any questions, and then I can go to a slide as necessary.
Thank you, John. Really great information and data. And this will be really helpful as we're thinking about, the advocacy work that Leading Age Maryland will be doing on behalf of members this upcoming legislative session as well. We do have one question in the chat from a member who's asking about if you have data specific to comparing not-for-profit to for-profit as it relates to nursing PPDs. I couldn't remember if that was in one of your slides. If not, I know I can get that information from our kind of data partners at Leading Age New York. But did you have that in there?
Yes, you mean, no, I don't have it in the presentation itself.
Okay.
I mean, clearly with the background on the database is all facilities, so it could be parsed out itself. But you mean the hours per resident day?
Mm-hmm.
Yeah. No, I didn't include it. I mean, it wasn't intentional. Why not? Or like just an oversight. I guess I was just looking at. I mean, these days, like I mentioned before, it's challenging for all providers. I mean, to make money, much less break even. So I guess that's why I didn't think of including it when a personal oversight or anything like that. It's just I know all folks are trying to be as efficient as possible these days in providing their care.
Right. Any other questions from our callers today?
Yeah, I'd say in closing for comments, I know a lot of the data whenever was negative. I can recognize that. I don't want to. Let's say from a positive standpoint, I would look at if you're looking at meeting these mandates, and you already know you provide quality resident care. Okay, so I'm not implying that anyone's trying to skimp out or not fulfill their duties, provide resident care, or even more than their duties and their mission and things like that. But I mean, it does seem interesting that, like I mentioned before, if the 5-star mentions allowing some positions that are not direct care, traditional direct care in its 5-star calculation, it does appear that could be positive as well. So it's to what degree, yeah, here it is, the nursing staff will measure. So there are more administrative duties within the mandate as well. So anyways, I guess that's a positive outlook, as opposed to taking historical, how we would in the industry historically calculate some direct care hours per resident day for budgeting or scheduling, things like that. It does appear like nursing staff level, even though they may come out with a high staffing level requirement to meet whatever they want to speak to, it appears like in the calculation, there may be other supporting positions, administrative duties, maybe able to layer it in the submissions itself. So I guess trying to find some positive as a way to just say things are going to get much worse in the future.
Thanks for adding that, John. Yeah, I know that folks are working to provide the best care possible with sometimes a small pool of individuals that they're working to recruit and retain. And so it's helpful to just kind of see these numbers and the data and look at the situation from a different perspective. So we appreciate so much you putting all of this together and sharing it. I guess would just love to hear from your perspective, as you're working with clients. Is there anything else that you think is helpful for providers to be thinking about as we're going into the next year? Any other kinds of hot questions or topics that you're hearing a lot about that you think would be good for folks to be thinking about?
I mean, I know a number of providers are looking to downsizing their nursing and evaluating that currently. Whether it's just closing a wing and or repositioning their facility completely. Just from a CCRC standpoint, how many nursing beds do you need to fulfill your commitment to residents? And then what can be done, either in their apartment and or assisted living, right? It still provides quality care for the resident. That you want to do from a mission standpoint. So my point is that that'd be a key factor consideration is for some of these nursing costs. It is looking very challenging within nursing facilities. And like I said before, those that are focused on the most efficient staffing possible, which are some of those for-profits, not all, but some for-profits, and then private equity investors in them. I mean, the private equity investors themselves are thinking it's going to be a 3 to 4 year break even standpoint. Okay, so that kind of tells you something. Like even if the people that only do it for return on money are thinking that it won't provide a return until 3-4 years from now, that kind of says that from a nursing standpoint, it might be worthwhile during this time to evaluate the number of nursing beds in your facility, in your CCRC or life plan community. And if all you have is nursing, I understand that as well. But I think I know a number of providers are reevaluating that, and you got to fulfill your commitment to residents, I'm sure. But it's just, I know a lot of people are going through, and then, how do you size that? Because it's the next 2 years look like very tough, at least in providing in nursing.
Yeah,
definitely.
Allison, can you hear me?
Yes, I can.
Thank you. Hey, John, great information. This is Jim Doherty from Fulton Bank, and I didn't text the question in on the bifurcation between the for-profit and nonprofit, but I think that would be great info, and I would think it would probably come in somewhere around 3 and potentially close to 4 for the nonprofits or greater. But I did want to touch on, and you started to touch on. So Fulton does a significant amount of business with nonprofits, and obviously this is a leading age discussion, but there is a tremendous amount of buying and selling that is occurring on the for-profit side. And with what you just said about mandates and the likelihood that they are going to be pushed, or even if incrementally, and just the reimbursements and labor costs, what are people seeing in that nursing area that they're saying, okay, this is a profitable future? And we as a bank have been very conservative about, moving into that space. So my question is, what do they see that we don't see, or what do we see that they don't see that's causing people to be out there buying facilities, both for and nonprofit, that are, principally still skilled nursing facilities?
I think, I know I'm working with someone now. It's in discussion of selling a number of their nursing facilities, and so they're to have a sale, you have to have a transaction of 2 people, right? So someone has to be buying it, and they're looking at opportunity. They're looking at just historical opportunities of pricing, and I guess they're assuming that it's going to take 3-4 years to implement those savings. And that's why I know some is what one facility is looking for. They got 2 in a town, and they're going to buy one and make it focus on long-term care Medicaid. The other, they're focused on rehab from a nearby hospital, and then they're running analysis on behavioral health within it. So that's how they plan to get a return on their investment. They're going to buy 2 at a time, but I think it's just historical deals from that standpoint. And like I said, and for those that are physically in DC, which there aren't many at all, they're in nursing. But like I said, during the emergency, we're still in the emergency act, they're getting a 20% premium on Medicaid right now. And Pennsylvania did announce 20% premium, but like I said, they haven't finally defined their staffing mandates. So I don't know how that's going to come out. So yeah, I think it's just they're finding historical deals and on facilities itself. I mean, some of the nurse facilities are near real estate values. Not that real estate's worth that much money, but I mean, some of these prices are really low. I mean, they discussed evaluations around 3-4 million for facilities with 80-100 beds, right? So at that point, when you're getting that low, you're getting near real estate prices. I mean, real estate may be in excess of it.
Thanks for asking that question, Jim. I was wondering the same thing, just from John's perspective on the interest of these equity firms. So
I can't say behavioral health.
And
is
if I
where
can
everyone thinks
follow
it's
up,
gonna go.
I mean, because and I'll speak to Pennsylvania because we've had a lot of New York metropolitan area groups buy. And I'm just wondering if they're saying, okay, our mandate is much higher here and Pennsylvania's is much lower. But, hey, we can do better at managing than the people who have been. So we're buying those assets. And just wanted to, PLA's probably evaluated those. And, that's why I asked.
Right. Thanks. I do know behavioral health is where a lot of private equity folks are looking into. No, I mean, assuming they understand it, which who knows, but that's where they see all the, from their market analysis and demand studies, they see a lot of behavioral health from addiction services to mental health to geriatric behavioral health. They're just seeing more opportunity there from getting return on investment.
well, there's certainly need there, so that makes sense. I wanted to note that I just put in the chat, I just got this link during the call, but Leading Age New York, through their 5-star analysis, shares a overall trend report for each state. So I put the link to the report that includes the changes to the staffing measure calculation. And it does break it down by for-profit, government, not-for-profit, and then the entire state in terms of the measures. So feel free to take a look at that. I think it has a lot of the data that folks maybe were wondering about comparing the different parts of the sector. So just wanted to note that.
Okay. All right. Well, thank you all. Yeah, nothing else to add, but I'm happy to answer any questions or speak to any topic.
Thank you. We so appreciate your time today. And most of this was recorded. We forgot to start recording at the very beginning. So that will be up on our YouTube page. So feel free to share it with colleagues. And we will get these slides sent out to everyone who had registered for the call today. John, thank you so much. And we look forward to having you back again sometime soon.
Okay, great. Thank you all. Thanks to the members. And thank you, Allison. Appreciate it.
Take care. Thank you. Bye-bye.